You want me to change the slides?
I got it.
You got it? Okay.
Good afternoon, Mr. Chair and committee. Stephen Stack, Commissioner for Public Health. And I guess it's to me. So
Yes, it is.
for the end of the public health emergency, this is a welcome time for all of us. It's certainly a welcome time for the public health community that's had to work so hard during the pandemic. So most of our federal grants have run their course, and or the federal funding that we receive. So you look at CARES funding, that's long done. ARPA funding, that's long done. We have special and designated funding for laboratory, for disaster response, for health equity work. Those grants were supposed to end, most of them, at the end, June 30th, 2023, give or take a month. And they were extended, a number of them, to have an extended spending period till next summer. So the spending plan for those has already been introduced, and we're really largely in final execution and wind down for those grants. So that's what the first bullet mentions up there at the top. One thing you might notice for those of you who cross over when you do the budget next year, this last year is the final year getting money out. So this will be the last year that public health's budget is larger than what it might normally otherwise be for FY24. And when we get to FY25, the next biennium, we're going to recede back into more of what our normal footprint would be, if that helps. One of the many big things we've done is provide a lot of testing for COVID, particularly earlier in the pandemic and throughout. Almost all, well, actually, all of the regular laboratory testing is largely gone at this point, except for our ongoing support for long-term care facilities, so the nursing homes. There's about 300 or so of them, I think, that we support. And we have renewed the contract for one more year, and that will run through June 30th, and then the funding will exhaust, and that will be the last year that we do that support for. So we're just continuing a program that's already operating to help support the nursing homes, which is, as we know, because of the age of the population, one of the most vulnerable of all populations for COVID. For antigen testing, the things that most of us would use if we wanted over the counter that we have ready access to, the federal government provided support a number of different ways, financially, where we could purchase antigen tests, but also gave antigen tests to the states so that we could support schools, K through 12 schools, and other educational environments, correctional facilities, homeless shelters, the public health community. We have distributed a large portion of the tests we have on hand. We're continuing to try to distribute the ones we have remaining. Those are ones that the federal government purchased at this point that were given out to the states. And then we have a small amount of money still remaining over the next fiscal year, so the state fiscal year 24, where we'll be able to continue to provide tests for the health departments, and then they can use those within their communities to support high priority areas, the correctional facilities. The school testing support will dissipate, and that won't be there anymore. We found that there were a number of schools and districts this year who were interested, but there were quite a few who didn't want the tests, even though we offered them repeatedly. So it's just run its course. We're getting to the end of that journey. Most responsibilities for the COVID-19 vaccines and therapeutics either have ended, have transitioned, or are transitioning. So I'll give you examples. Remdesivir was the very first medication that was approved for use for COVID. That's all on the commercial marketplace now. It's a regular medication, fully approved, and it's purchased and provided at the discretion of physicians if they feel it's appropriate. Monoclonal antibodies that got a lot of attention during parts of the pandemic, those are gone. There are no more monoclonal antibodies. Every time the virus changed substantially, you had to design a new antibody for the new virus. And there's just not the demand for it at this point. And the combination of the number of people who have some immune protection because they've been infected, plus the number of people who've had the vaccination, plus the large, probably majority of Americans who've been both infected and vaccinated, that in the changing of the virus has made those therapeutics no longer economically needed or just sustainable or needed. The oral antiviral medications, Paxlovid, you see that on commercials and TV. That's largely commercialized at this point, but the federal government still has a supply of that, And so that's available still at no charge for the medication. You may have to pay the pharmacy fee to have it dispensed, but available at no charge for the medication for many people. But that will all be commercial here very, very shortly as supplies run out. And as far as the vaccines, the federal government has the most current bivalent vaccine and still has supply of that. So you can still go get your bivalent vaccine at no charge right now for the vaccine itself. And again, now that the emergency has ended, you may have to pay a pharmacy administration fee, which your insurance company would typically cover. This fall, if there's a new or revised vaccine, that'll all be the commercial marketplace, with very scant exception if the federal government's able to put together a program for people without insurance. And then there'll be a designated places you could go to get that, or ways to get it if you don't have access to healthcare insurance. So really, all of this has been mainstreamed into the regular healthcare system for the most part, and what tail part has not been is in the process of transitioning. And then another huge task that we did very early in the pandemic and throughout the peak parts of the pandemics was data collection and analysis, and that has also largely normalized into routine approaches that we use for other diseases, so that we every year provide a flu report during flu season. We don't typically provide an RSV report. We have provided really substantial analysis in public reporting for the COVID pandemic. But now if you go to the website, like has happened in states all over the country, that has largely consolidated to very few data points because the hospitals just aren't being overburdened by COVID right now. So it's no longer necessary, and the data is not actionable in the way that it was earlier in the pandemic. So it's not over. COVID still exists. COVID is still out there. People still should get vaccinated to keep themselves protected. But as far as the profoundly enhanced public health support for it, that has largely wound down. And what we'll have in 24 is the final execution of the remaining grant dollars that we have. And we will have to have some continued narrowing of our staffing, and predominantly in our disease management and tracking, where we've been able to do some extra and enhanced work because of this funding. And that'll have to normalize into sustainable funding streams as the federal funds go away. And then the final thing, which I don't have any answer yet, none of us do, is the result of the debt ceiling discussions federally. There's a clause in there at Section 81 that's only 3 lines, gloriously short with possibly profoundly big impact for some of our programs. Unobligated funds are going to be taken back to the Treasury. And so we have to see how they define obligated, whether it's when they assign it to us, when we spent it, or when we have it budgeted. And that nobody knows the answer to, and the president just signed that into law yesterday, I think. And so we'll find out in the weeks ahead what the implications of that are and do our best to adapt. And so that's all I have, sir.
There was an FAQ that said, well, what is the federal government going to take back? And they said, well, unobligated funds, and that was it. And so we're still reading tea leaves. We don't know. There was a table that was provided of the grants. My eye, right, looked to me to be too small to be a huge take back from the states. But again, I don't know what unobligated means. I mean, I know what the word means, but I don't know what it means in federal speak. So we're still monitoring what that impact's going to be, and I think we might know, but we don't know. And it's a profound difference, not only for public health, but for the Department of Community-Based Services, which you'll hear from next. Those are pretty profound differences between those two.
And we just have one slide for public health here today. So we're at the question point now if you have any questions.
I guess I'm curious as to what public health looks like going forward. And you've heard me say before in committee meetings that one of the good things about COVID, if there is a good thing, is that it, I think, heightened the public's perception of health departments and the services they offer. I think they were kind of an afterthought before this, and we understand they play a very vital role. And I guess I'm looking to try to determine what that role looks like in the future. I think there's tremendous potential for them, particularly in the area of improving the health of the population, but that's not a responsibility we've necessarily delegated to them as a priority. I think it could be, should be, but you've already acknowledged that we're probably going to see a contraction in our labor force within the public health department. Can that be mitigated to some degree by, again, expanding the roles, responsibility of public health?
Well, so a contraction because of the COVID-related work, but let me urge the legislature. You've done a great job, and you still have important work to do in the next biennial session for the next biennial budget. The public health transformation dollars you've given in this funding period have been really, really important to helping to sustain public health transformation going forward. So remember, in 2020, House Bill 129 passed, and that structurally changed how funding would be done for public health departments. But the funding didn't come because the session got cut short, but then all this COVID money came in. So it largely kept everything afloat, but it kept everything afloat because the entire public health system really focused on one problem. Then the legislature came through and appropriated money, 17 or so million one year, 19 or so million another year, to help support the local health departments to do core and foundational public health services, as well as the local health priorities that are part of the transformation effort. So that work is well underway right now. I would say COVID has obviously been disruptive for all of us. I mean, that's undeniable. I mean, there's no one on the planet really who hasn't been touched by this probably. But it wasn't all bad for public health. It was horribly stressful, and it burned people out. And of course, there was division within society about perspectives about should we have done this or should we do that. But what it did do for Kentucky was it brought us together in a way that hasn't happened for a very long time. And so I have viewed, and I would have done this at the start, but COVID made it really apparent and overt. I see the 61 local health department leaders as the chief health strategists for the jurisdictions they're responsible for the public health strategy. And I see my role as supporting them and empowering them and working together as a partnership. So Kentucky Public Health is the partnership of those two layers, the state and the local together. And the public shouldn't have to notice much of a difference. It should be Kentucky Public Health, and behind the scenes we work together. The public health transformation dollars, along with our efforts to continue to transform public health, will help, and it is helping now, the local health departments to be more solidified, more stable. We did rate increases for the salaries for the state health, for the public health workers in the state health system the last 3 months of last year that people haven't seen in a very long time. And we've got stories about people who thought they would lose their house, people who were worried their husband was going to die or their spouse because they had a terminal illness, that they wouldn't be able to support themselves after they passed on. People who'd been in public health 15, 20 or more years and not seen those kind of salary increases, that they now have a wage that makes it possible to continue to do that and be sustainable. And it's helping recruitment because, you know, when you can make $15 an hour to work in a fast food service industry and you were going to get paid $11 to work at the health department, it made more sense to go work in the service industry economically for families. So we are much more stable. I'm absolutely confident that Kentucky Public Health is better at this stage than it was 3+ years ago. They will be hesitant to invest in judiciously. And again, I don't want anyone to build a cliff-financed workforce. We don't want to have to ever go back and do reductions in force if the revenue goes away. But there is a need to judiciously invest in some expansion in selected places. They'll watch very carefully and see if the continued support for public health transformation continues in the next biennium, which will help to make that possible. But I think you should feel very proud, and I hope you'll take a moment when you have a chance to thank the public health directors that are in your jurisdictions and your districts. They really are leaders in their communities and have done a wonderful job. And we dialogue and communicate so much better than we did before. Plus, and I know this is a long answer, Mr. Chair, but we have done other things that have been good. We onboarded hundreds and hundreds of additional labs into KHI, the Kentucky Health Information Exchange, that now electronically report their laboratory test results for reportable diseases, and some of them and more on an ongoing basis doing electronic case reporting, which is when they have to report clinical data for folks who have reportable diseases. This is where the electronic health records help to save time for clinicians who are burned out themselves and overworked, but also for public health to get more quickly, more accurately, more efficiently that data. We have a warehouse that now has gowns and gloves and masks and new ventilators and resources we did not have. And those can help for floods and tornadoes and ice storms and windstorms, not just for global pandemics. We also have invested in, what I blank, there's at least two other things I was going to share. Oh, some of our disease management teams. We hope this fall we'll have a new respiratory disease dashboard. So instead of just doing influenza, we can look at influenza, COVID, RSV, to try to give a more useful view of the impact of respiratory illnesses in the fall and winter, and stuff that the public can actually see on a website and actually use if they choose to do that. So we are better and we are stronger, but I agree with you, Senator. What we need to see now is can we have a stronger public health system help to improve and strengthen the health of the public? And that is the mission of both the department and the cabinet, is to have healthier people and healthier communities so everybody can reach their full human potential. And we're committed to doing that, but we had a lot of rebuilding to do. And I think despite and because of COVID, the Kentucky public health system is better off today than it was a few years ago.
I'm curious as to what happens with the next communicable disease outbreak, whatever it might be. Are we have to admit we were kind of reactionary because nobody knew what we were dealing with. Is that kind of an indictment of the system? Because we're dealing with communicable diseases, does it have to be so COVID specific? Should we have processes in place that, regardless of what it is, if it's COVID-29, that we're better prepared next time than we were this time? So have we had those learning experiences through this experience?
Well, COVID was unprecedented in any of our living history because all of humanity had no immune exposure to it. It was a brand new disease that we had nothing prepared for it. So we had no testing, no treatments, no vaccines, nothing. So that's what made that so seismically different. If we were to have a hepatitis outbreak or, we actually have, unfortunately, increasing syphilis. We have multi-drug resistant gonorrhea. We have yeast infections that are alarmingly dangerous and difficult to treat and hit vulnerable folks in institutionalized settings. Those are really, really serious problems that require antimicrobial stewardship, the pharmaceutical industry to develop new and better drugs that respond to the situation. But I think for those, I think we have a more strengthened network. If we had another brand new infection that all of humanity had never seen again, I hope we would do better. But I would just say what really was difficult then was not just the lack of knowledge. It was just many of us look at the world and we just see it differently. And it becomes divisive, if not in the beginning, like in the first few months, but very quickly thereafter, because the types of actions that had to be taken were so substantial, because the risk was so substantial. So I think as a society, we just have to continue to try to do the best we can to recognize what are those moments that really rise above the typical differences of view to like, this really threatens us all. It places a real danger to so many people that's why things are done differently. I wish I could say we're going to do better if that were to happen again. But I think I study history. Humanity's been humanity for a very, very long time. And all I can say is I think in Kentucky, where we still have differences of opinion, I travel all over the state, and I'll be guilty. I stopped at a McDonald's, and I feel badly. As the health commissioner, I don't feel like I should probably be eating at McDonald's.
I saw it on Facebook, yeah.
And some nice woman with her 2 middle school kids said, I feel like I should say thank you, which I thought was very courteous. And I said, now I'm embarrassed because look at the example I'm setting as the health commissioner. But it's all I had time for before I came over here. So, but the point I would say is that as I travel around the state, people say thank you all over the place. And people say thank you regardless of party and even identify party. And I don't think that means they agreed with everything. I don't think that for 1 minute. I think they recognized, God, that really looked terrible. It was terrible, and thanks for at least trying. Yeah. And so I think if we continue to find where can we cooperate on things, I think we would do better, Senator. But I also am sanguine about it. It'll continue to be a challenge because humanity is just humanity.
And I guess